Thank you very much. Dear Dr. Glickson, dear Dr. Vardas, dear Dr. Pinto, thank you for having me here. Thank you to the Israeli Cardiac Society to be here once more. I came last year to see you and I enjoyed much. And I will speak about comprehensive imaging in heart failure. Heart failure is a difficult disease, and I think we can help with imaging to actually contribute something. I'm just seeing how So I like to always take the lectures with case examples, that you just look at patients that you see that I saw yesterday until 7 o'clock, so I was getting very tight if I would make it here today. This is a man, 62 years old. He has one infarction, 87. He has another infarction, 88. He has another infarction, 94. He gets bypass surgery in 96. And he has a non-sustained ventricular tachycardia in 2000. By then we were not as aggressive with ICDs as we are now. Now he would have an ICD immediately, although you could question yourself about these decisions. He has comorbidities. All these patients have comorbidities, pulmonary disease, diabetes, and most of them had chronic renal failure, in this case quite severe. The patient presents with reduced exercise capacity. He is in New York class 3. He has dizziness. He has hypotension. His weight is 53 kilos. His blood pressure is a bit low. And as many of these patients has a holosystolic murmur on the apex, which represents mitral regurgitation. So I like, as I did with you last year, when I came to present these clinical dilemmas in sorts of questions that you have. I start to do that more and more, and I teach that to the fellows also. Do not take everything from what you have in the imaging suite, but just ask yourself first the question, specifically in this sort of more complex patients. What do you need to know to treat these patients? And what you want to know in this patient is his LV function, his LV size. We know that he has coronary disease, but for completeness, if you have a patient with severe heart failure, one of the first questions is, does he have coronary disease or not? If he has coronary disease, which is about 70 to 80% of the patients presenting in the Western world with heart failure, they have ischemic cardiomyopathy. Does he have ischemia, or is there residual viability? Does he have severe mitral regurgitation, as our patient here certainly had? And does he need a device? And we put here ICD, but you can also put there ICD CRT. One thing that we know, this is the work from Harvey White many years ago, 86, where you see very clearly once ejection fraction goes down, mortality goes up steeply. When you present this sort of slide sometimes, people say, that was so many years ago. Now we have all these pharmas, and with all these drugs we can really help these patients. But what was very interesting to see at last ACC meeting was that the stitch data in this sort of patients were presented, 10 years outcome, and if you look at it, more than 50%, I would say 50% at 5 years, and more than 50% were dead by 10 years. So we do a lot to the patients, we help them a lot, but the outcomes are still not good in these patients. And the lower the EF is, the worse the outcome is. So what do? We do simple echocardiography. We're not going to do all sorts of fancy things. We need to know LV function and size. If you have, like we have a tertiary referral center, we see a lot of these patients in the week, and we cannot do MRIs and very advanced imaging in every patient. We do about, I would say, 100-something echoes per day. And in most of the cases, it gives you the information. This is actually the upper two echoes are the ones from the patient that I showed you. So you see he has inferior infarction, you see he has a big anteroapical scar. And what we like to do in these heart failure patients is actually that we add the contrast, as you see in the bottom part. Why do we add the contrast? Because you see so much better where's the function, where's the akinesia. But what you also pick up, as you can see here in this patient actually, is that he has an apical thrombus. And this is important in the patients where we have lots of anteroseptal scars, because you see quite often that they have thrombi, and specifically the protruding thrombi are a problem. The contrast is not dangerous. You give it intravenously. There was some discussion about that years ago. This is completely benign and not expensive to use. So where is the field moving? The field is moving step by step in the direction of three-dimensional imaging. You saw just in the very nice talk by Dr. Hendricks that everything we like to visualize will eventually become in 3D. When Jos Roeland at the Thorax Center in Rotterdam told me that so many years ago, when it took about a full day to post-process one of these images to get the images like this, I said, this is never going to make it. But now you have a probe, and the probe acquires this view, and this view in once. And so from these three acquisitions with one shot, you can then post-process the three-dimensional ventricular structure. And again, if you give the contrast, as you see here, it's very easy for the software to post-process that. What are the other more beautiful techniques? Of course, much more beautiful is MRI, as you see here. The resolution is so much higher, you can pick up almost everything. And we need to think about, when do we really know this? At the moment, when do we really need this? At the moment, as the guidelines stand, that you need an ejection fraction below this or that to give a device, probably we do need the highest resolution imaging. And probably in those cases we use an MRI. In the future we can also think about using this. This comes from the CT scan, and this is LV function in a severe heart failure patient. But at the moment, as it is now, this comes actually with significant radiation. That brings it up to about 10 millisievert and plus. So I think this is at this moment not something that you routinely do in the patients. LV function and size. So we need highest resolution images in every patient. We want to assess ejection fraction. We also want to look at the dimensions. We also want to look at the volumes. The exact quantification is probably important for prognosis, but probably even more important at this moment in time for justification of devices. What else are we going to do in the future? We're going to use more and more echo. We're going to use this echo strain, as you see here, where we can measure and quantify the deformation. And here you have all these different colors, and these different colors correlate with different regions. And then you get this sort of different curves here. And the dotted curve here is the average of the whole ventricle. The fact that it's negative is because it's a longitudinal strain, which is the up and down strain. And then we use again the same probe that we used before, which takes the 2-chamber, the 4-chamber, and the 3 or the 5-chamber in one shot. And with this one shot, we can then post-process this bullseye plot here, which is very similar to the nuclear that we are used to. And you get then, in this polar plot, a global strain of the ventricle, which is actually the active deformation of this ventricle. And actually, if you look at normal individuals, the number for a normal strain is about 20. Now I'm going to give you 3 clear examples. Here is a normal, minus 19, minus 20. Here is an infarction. This is acute myocardial infarction, in this case in the inferior region. It's very easy to pick up where the problem is, and you see that the strain in that region is completely gone. A localized infarction, a localized problem, reduces the strain in the direction of, let's say, 14. If you develop severe heart failure, as our patient, you go in the direction of a strain like 7. So the numbers to remember, 20 is normal, 15 or so is an infarction, and about 5 to 7 is severe heart failure, corresponding with an ejection fraction, let's say 20%. In the future, we can also start using these sort of things. These are flow patterns. How does the blood flow in a ventricle? And we have applied this in different sort of diseases with the 4D flow measurements that are nowadays possible. And you get to see a lot of different flow patterns in different diseases. I'm sure that we will use that more in the future. Okay, if we speak about the next step is detection of coronary disease. If we don't know the patient has coronary disease, we do in every severe heart failure patient directly angiogram, no matter what the kidney function is. But you could anticipate that in the future we're going to do more of the CT scans, because if we do CT scans, we get quite good images nowadays. We can post-process them, and we can see the exact course of the coronary arteries, and we can detect quite easily the stenosis in the coronary arteries. What do we use it for at the moment is to rule out coronary artery disease. Really there we have a negative predictive value reaching 100%, indicating that if you have no stenosis, no atherosclerosis, there is no coronary artery disease in this patient. That can be useful sometimes, because this is another example that I take for you. It's a 57-year-old woman. She has 2 times TIA. She doesn't have heart failure, as you see here. So we do an echo just for the analysis of the source of embolism. You see that she has a huge myxoma, so she has to go for surgery. If we now send her for surgery, we learn that she has smoking history of 39 pack years. She has high cholesterol, 7.8 actually. And so we did in this case CT scan to look at the coronary arteries. And these risk factors do not always translate into coronary artery disease. Because if you look here, she has perfectly clean coronary arteries, despite the high cholesterol, despite the extensive smoking. So, step 1, I think invasive coronary angiography, but maybe in the future more and more shift towards CT scan. Then we need to talk about ischemia and or viability. If we speak about that, we think about the ischemic cascade. Here you have the time from onset of ischemia, and what happens is that you encounter hypoperfusion and later on systolic dysfunction. And it is these things that we are used to image. We use a nuclear scan, for example, to look at the perfusion, and we can measure precisely the extent of ischemic myocardium. And you know the phenomenal work from Dan Berman's group in Cedars-Sinai. They show that if you have more than 15% ischemic myocardium in the ventricle, you probably better revascularize than to treat medically. We can also use a stress echo. We do all of this with contrast, as you see here. And you see how easy it is to pick up the border definition and to see where the problems are. So here we're looking for wall motion abnormalities. We can do the same with an MRI. We do it sometimes. Not that often. And you can also assess the perfusion with an MRI. There are quite some centers in the UK specifically where they measure this perfusion, and you see here in the perfusion abnormalities, which was all over the place, subendocardial, this patient had severe 3-vessel disease. Now if we speak about viability, then I give you 2 slides. One slide is the one from all the retrospective studies where we saw that in the revascularized patients, when there was viability, the outcome, the event rate was the lowest as compared to all these other groups. How do we assess viability? We can do with nuclear scan again. In the bottom here you see the perfusion scan where there is a big anteroseptal infarct. This is the patient that I showed you in the beginning. And you see that he also has an inferior problem. So he had the 2 infarcts that I showed to you in the beginning. And you see if we do the glucose scan, the FDG scan, that especially this anteroseptal region is containing a lot of glucose utilization. So there is here very hypoperfused myocardium, but has a lot of glucose utilization, so it is still viable. More and more we use in this case MRI. But there is just one word of caution, because the white here you see the long axis 4 chamber with the white is the scar tissue, so in this case a non-transmural lateral infarct. This is almost a transmural anteroseptal infarct. One word of caution, what you pick up here is scar. You do not pick up the areas that are dysfunctional but still viable. And just one word on the STITCH trial. I think the STITCH trial was a very good trial pointing out a lot of things. But if you start looking for viability, I think you need to start from the area where there is no good function. You start with the dysfunctional area. And there you question yourself, is this dead or is this alive? And that's the one thing that was skipped in the STITCH trial. And that resulted in that all these ventricles, 500 out of the 600, were viable. And if I ask you as clinical doctors here, and you send your patient with an old infarction like the one I showed to you, how often is this infarct area viable? I would say less than 30% normally. So if you have 500 out of the 600 being viable, the issue is that they use the whole ventricle, including all the normal functioning segments. And I think that question of viability is important when you focus on the dysfunctional myocardium. Again, the future. I think we will see more and more fusion imaging. This is fusion imaging with MRI and PET. So you could do the delayed enhancement with the scar and fuse it with the glucose PET scan, then you would see the scar in correlation with the viable areas. That would be perfect to have a whole picture of the ventricle. If we now speak about severe mitral regurgitation, you saw in the case that I presented to you, this patient for sure had severe mitral regurgitation. If the mitral regurgitation is absent, or if the mitral regurgitation is present, there is a big difference in outcome. So it's a total miss if we send the patient for revascularization and you have to send them again in 1 or 2 years for severe mitral regurgitation. So you need to assess that. And how do we do that? We do it with transthoracic, very simple, transthoracic echocardiography, and we use sometimes transesophageal if we want to have a better discussion with the surgeons. Also in this field, we see a gradual shift from 2-dimensional to 3-dimensional. We use more and more in all this valve disease, going away from 2-dimensional and using the 3-dimensional imaging. Is the quantification of this mitral regurgitation important? This is the work from Patrizio Lancelotti, and you see here that if there is a lot of regurgitant blood volume or much less in yellow, that there is a different outcome. The more regurgitant volume there is, the worse the outcome is. How do we do that? It's very difficult, and especially you see that when we try to judge the MitraClip studies. Nobody knows really how to measure the endpoint in terms of severity, mitral regurg after MitraClip. You could do an MRI. I've shown this slide a couple of times. It's an older study that we've been doing. It works. It works very nice. You can put scouts on all the 4 valves as you see here, and then you get the flow encoded, velocity flow encoded MRIs. And if we take out the one on the mitral valve, you see here that we can precisely measure the forward volume, the backward volume, and quantify the regurgitation fraction. This looks just as a normal flow, what you see with echo, but now purely quantified. This is feasible. It costs time. There's a lot of artifacts, but it is feasible. And I think before we all shift in the direction that everything needs to be quantified, we need to think if this is really needed. For the moment, we don't have this clear data that we need to do that in every patient. We, in our center, do not routinely do a quantitative MRI. We just work with echocardiography. As I said, it's not only the function in terms of how much regurgitant volume there is, but it's also important to see what this valve is doing. And here you see a big prolapse, and here you see another view of the mitral valve. And this is information that is important for the surgeon. How is he going to structure his surgery? What is he going to look for? So that field is surely going to move from 2D to 3D. The last question that you then have is, do we need an ICD? And this is what I spoke to you about last year. It's very difficult to define the patient that need an ICD. So if you look at the moment in guidelines, we use an EF of less than 30 or 35%, depending a little bit on the details. If we look at the MADIT study, the MADIT-2 study that actually shown the benefit very nicely in ICDs in primary prevention, here is 720 patients, and you see that 65% never got a shock over the follow-up years and 35% did. And that calls for some action from us as cardiologists that we need to better structurize, get a better view on which patient do need an ICD and who doesn't need an ICD, because the ICD comes with inappropriate shocks, lead infections. So this is the slide from Bill Stevenson that I always like to show. The center is always a core infarct. Then you have the remote, which is normal myocardium. And it's the transition between the core and the remote where the business takes place. This is not new, has been shown by Doug Zipes years ago. In the 1980s, he already showed these animal experiments. And so we like to visualize this transition, which is here, from the normal black myocardium to the red, which is the pure core tissue. And you can do that. You can quantify that. You can use different thresholds. And this border zone is important actually in relation to shocks. We did one study that we published some years ago, and you see here, if this infarct gray zone, which is the border zone, get bigger and bigger, the more shocks you see on an ICD in this patient. So it tells us something. It tells us something that we need to learn more about this to eventually in the future stratify this one needs an ICD and that one doesn't need an ICD. It will prevent events and it will also save a lot of costs. I have tried to show you that severe heart failure patient is complex. It's very complex. It has a lot of comorbidities. Step 1 is LV function. Step 2 is basically what we do, direct invasive angiography. Maybe in the future something else. Step 3, once you've done angiography, you want to know about the stenosis. Could be an FFR in the cath lab. Could be something that you've done before, like an ischemia test. That what comes later then is the viability, if you think you need it. What comes after is the mitral regurgitation. And the part on the ICDs is purely research at the moment. It's not something we use. With us, all the patients, 30-35% ejection fraction, get an ICD. We can get all this information with imaging. I think we need, as cardiologists, we have the duty to not throw all this imaging at these patients. We need to select what we need, and based on that, we make the diagnosis and we determine the treatment. Imaging will always be there, but it will only sustain the test of time if we actually use it selectively and if it has an impact on outcome. If not, it's just pictures for pictures. Thank you very much.